Good morning, good afternoon, good night, depending on where you're joining us. Thank you so much for being with us in our 15th site presentations, where we will be talking about tissue Doppler in the NICU, the utility and the pitfalls of it. Our speaker is Dr. Phani Kiran Yajamanyam, who's an attending physician in neonatology at Sidra Medicine. He completed his training in neonatal perinatal medicine along with a 2-year research fellowship in neonatal echocardiography in the United Kingdom in 2014, and subsequently became a fellow at the Royal College of Pediatrics and Child Health in 2016. His research interests include neonatal hemodynamics and neonatal infection, and he also has a keen interest in patient safety, as is the NICU lead for patient safety. For the panel discussion, we will be joined by Adrianne Bischoff, who's a clinical assistant professor and neonatal hemodynamics specialist at the University of Iowa with expertise in cardiovascular physiology, specifically in the post-PDA closure and neonatal hemodynamics. We will also be joined by Dr. Samir Gupta, who's the Division Chief of Neonatology, Hemodynamic Faculty Lead and Training Program Director at Sidra Medicine. He's the Program Director of Qatar Neonatologists with an interest in cardiology and hemodynamics with the Q niche program. Then we will also be joined by Dr. Srinath Krishnappa, who joined Sidra Medicine as a neonatal hospitalist in 2020. He has special interest in neonatal hemodynamics and has recently joined the newborn hemodynamic group in the NICU after completing the Q niche functional echo training program. And we will be joined by Dr. Phil Levy, who's an assistant professor of pediatrics at Harvard Medical School and staff neonatologist at Boston Children's Hospital, who has research initiative on cardiac mechanics and congenital and acquired cardiopulmonary diseases. Thank you so much. Go ahead, Kiran. Thank you so much. I think you're muted.
I am unmuted now, yep. And I have shared my screen just for the slides. And thank you very much for the kind introduction. I am very glad to be talking on this platform. And good day to everyone who has joined from wherever you are in the world now. I'm very happy to be talking about a topic of a keen interest for me, tissue Doppler imaging, its utility in NICU, and the careful considerations that we should bear in mind while using it. And I hope by the end of the session, we will have some discussion with the panelists and probably some interaction with the audience that I will probably end up learning more by the end of the session. So kicking off, this is the brief outline of my talk today. And I will go through the history and evolution of tissue Doppler imaging in neonates, the practical considerations that we should bear in mind, as I said, when performing TDI, the established and documented uses of tissue Doppler in neonates, and at the end, hopefully summarize the advantages and pitfalls. So tissue Doppler imaging was first described in 1989 by a group of cardiologists in France. And they first evaluated this technique on a bunch of adults who were in their cath lab for various pathologies, such as dilated cardiomyopathies and coronary artery disease. As we all know, it measures the velocity of myocardial motion and is based on the Doppler principles that everyone who performs echocardiography is very familiar with while measuring blood flow velocities. Different machines from different vendors have various software algorithms which are similar, and they differentiate tissue velocities from blood and only display the higher amplitude, low velocity myocardial velocities while using tissue Doppler imaging. We can say that this technique is now very well established, validated for use in children and neonates, and is now recognized as an essential integral part of a comprehensive echocardiogram. Tissue Doppler imaging is mentioned as an essential part of the evaluation while performing pediatric echocardiogram by the American Society of Echocardiography. In the recently published guidelines and recommendations for targeted neonatal echocardiography by the American Society, their recommendation says that when normative data is present, tissue Doppler imaging provides additional information on myocardial performance, and it should be included in the standard targeted neonatal echocardiography assessment, and especially when there is disagreement between other conventional modalities that we use. We are fortunate that it has been extensively researched in various neonatal populations since its first description in 1989, and this graph shows that a simple search on PubMed shows the number of articles published about tissue Doppler imaging in neonates. And as we can see, in the last decade, there has been numerous articles from various groups across the world that has helped us reach where we are in the use of tissue Doppler imaging. Normative data have been published and validated and are well recognized. However, the guidance on image acquisition and analysis is quite key because tissue Doppler measurements are prone to easy misinterpretation. As part of the training program we hold at Sidra Medicine in Qatar, the Q-Niche program, we follow the guidance and recommendations published by the European Special Interest Group Neonatologist Performed Echocardiography, which published a series of articles in the Journal of Pediatric Research, I think now 5 or 6 years ago. So for all our trainees and for our clinical use, we use these publications as reference standard. Just a brief mention about the pulse wave and color tissue Doppler imaging. Conventionally, pulse wave tissue Doppler imaging has been reported more extensively than color TDIs in adults, children, and neonates as well. Essentially, the technique is exactly the same, or the principles are exactly the same, even though the technique is slightly different. Color tissue Doppler actually provides the advantage of much more detailed, comprehensive analysis, which can be performed offline. For those who perform both of these are the differences that we have to bear in mind. Pulse wave tissue Doppler imaging provides the peak velocities of the myocardium, whereas color tissue Doppler imaging provides the mean velocity, which means that the velocities by color TDI are generally lower than the velocities by pulse wave. And about 20% is what generally it's recognized as the color TDI velocities are lower. As I said, color TDI requires offline analysis, but that has the advantage that the velocities can be measured from multiple segments at the same time, whereas conventionally pulse wave TDI just offers velocities just apical to the AV valve of both the ventricles. In color TDI, we have the additional advantage of measuring, because we can measure at multiple segments, the measurements can be taken from both the ventricles at the same time, the same image, and that is not possible in pulse wave. Both of them essentially are known to be dependent on loading conditions. And in literature, pulse wave TDI is reported to be more reproducible, or there is less inter-observer variability, but that is debatable. So for the rest of my presentation, I'll continue with pulse wave TDI, as that has been more reported across all neonatal populations. Again, very briefly to touch upon how it's done, again by convention, done in the apical 4-chamber view, although it can be done in the 2-chamber or 3-chamber views as well. As I mentioned, the pulse wave sample is placed just apical to the AV plane of both the ventricles. It can be measured at the septal level, lateral left ventricular wall, and the free RV wall, right ventricular wall. But it's important that all three are reported if done, because they're not interchangeable, and not in normative data. All three have been reported as separately. The sample gate volume is usually between 1 to 3 millimeters as recommended. However, I think the area of interest can be smaller to get more accurate, crisp images. I tend to use kind of 1 to 2 millimeters. Velocity scale is usually adjusted to avoid aliasing. And again, one of the advantages of tissue Doppler is the high frame rates, which offer, again, crisp images and accurate measurements. Some of the ways the tissue Doppler images can be optimized is by narrowing the sector width, like in this image you see the top image where the sector width has been narrowed to focus on the interventricular septum. Like with any other Doppler measurements, alignment of the pulse wave sample to the direction of motion of interest is quite crucial. And the angle of inclination as standard should be less than 20 degrees. So in tissue Doppler, we have to bear in mind, so the motion of the ventricular wall is from base towards the apex. So the pulse wave sample should align with that. And this can become sometimes quite challenging, and we'll touch upon that in the pitfalls. Particularly on the left ventricular wall, if the LV is volume loaded. And we often see that with hemodynamically significant PDAs. So in volume loaded left ventricles, where the LV is quite globular, alignment can be tricky. Again, in pulse wave, the gain should be optimal, not too much or too little, to get as accurate measurements as possible. So what is measured? Again, something we all are familiar with. The velocities measured are usually peak systolic, which are named S prime or S dash. Early diastolic velocities, E prime, which represent ventricular relaxation or diastolic function. Late diastolic waves, A prime. Again, these are all peak velocities in pulse wave. And that represents the atrial contractility. We can also measure the peak velocity in the isovolumic contraction time, and less reported, but probably worth more investigation is the isovolumic acceleration, and that's, as I said, is less reported in neonates. Among the time indices that are reported are the isovolumic contraction time, the IVCT, isovolumic relaxation time, the IVRT, and the ejection time can be measured. Myocardial performance index is something that can be measured. So this is, again, it was not first reported with TDIs. It was, TI index or myocardial performance index has been reported with normal measurements before the description of tissue Doppler imaging, but the measurement of MPI with tissue Doppler imaging is very comparable with normal measurements, and that's how it's calculated. So it's the sum of the isovolumic times divided by the ejection time, and it's usually a measure of global myocardial function, not just either systolic or diastolic, and various groups have described its use or the kind of the pros and cons of MPIs differently. So we know that tissue Doppler imaging has been studied in neonates both in normal state and in various pathological states. And again, from various groups across the world, normative data has been published, and I suggest these two references to the audience and for the normative data that is described. So coming to the crux of it, so what is the role of tissue Doppler imaging in NICU? And I guess the basic question is, do we need additional measures for hemodynamic monitoring, assessment, or management in the NICU? We know that there is increasing recognition of various pathophysiologies that underpin the perfusion problems in the neonatal population. And over the last decade, we've realized that one size does not fit all, and in neonatal shock, there are various pathophysiologies based on the disease condition. And the technological advances that have happened have given the opportunity to optimize the management of neonatal shock and improve outcomes. To me personally, I think tissue Doppler has shown promising evidence in one, early recognition of myocardial dysfunction that might lead to shock, better understanding of the pathophysiology of various disease states, and maybe the effect of treatments that we use, for fine-tuning the pharmacological or other interventions that we use in NICU, and maybe some prognostication as well. So over the next few minutes, I'll delve a little deeper into the studies that have addressed these points. So the most widely reported use of tissue Doppler imaging has been early recognition of myocardial dysfunction before it becomes clinically obvious, or before the more conventional courtside assessments can detect myocardial dysfunction. It has also been shown to detect preclinical myocardial dysfunction or suboptimal myocardial performance in different groups of infants. So let's look at this. So if we look at various groups of neonates or infants, in this study by Dr. Eirik Nestas from Norway, they looked at infants affected by late fetal growth restriction rather than early fetal growth restriction, and they performed echocardiograms on days 1, 2, and 3 on these neonates, and compared with matched controls. And they found, as you can see in this table, that conventional techniques of fractional shortening of the LV and right ventricular fractional area change were similar in both these groups. But when they looked at tissue Doppler imaging, and they looked at various different velocities and actually strain and strain rate measurements, but I've just for interest of time, I have put one measure that they have reported, which is the ratio of E to E prime, which again shows the diastolic function. You can see that as we know, the ratio, the higher the ratio is, more evidence of diastolic dysfunction. So we can see that there was statistical significant difference with more diastolic dysfunction in infants affected by late fetal growth restriction compared to appropriately grown infants on days 1, 2, and 3. And this was not detected by conventional techniques. Similarly, this group from New York looked at a large cohort of infants, and a single echocardiogram was performed in the first week of life. And the cases of interest in this study was infants of diabetic mothers. And they looked at 75 infants of diabetic mothers and compared with over 550 infants whose mothers did not have diabetes. And again, like the previous study, you can see that the left ventricular fractional shortening was similar between the groups when But then when we look at tissue Doppler myocardial velocities, the right ventricular peak systolic velocity, the S prime, and the early diastolic velocities at all three sides, so left ventricular free wall, septal, and right ventricular free wall, were all significantly different in the infants of diabetic mothers compared to control infants. So this shows that the right ventricular systolic function and possibly global diastolic function was suboptimal in these infants, but these infants were clinically well. So this study showed that the tissue Doppler imaging had the potential to detect subclinical, or you could call it preclinical, decrease in myocardial function in clinically asymptomatic infants of diabetic mothers. Similarly, looking at preterm infants affected by patent arteriosis, this was a study done kind of by where I did my research in Women's Hospital in the United Kingdom, where they looked at over 70 preterm infants born less than 30 weeks gestation. Again, a single echocardiogram performed on day 3 of life. Looked at, they categorized the infants into 3 groups: those who had hemodynamically significant PDA, had a PDA but did not reach hemodynamic significance, and infants who had no PDA. And there was about roughly 25 infants in each group. As you can see, infants with hemodynamically significant PDAs had, when you looked at the peak systolic velocities compared to the no PDA group, they had lower systolic, early diastolic and late diastolic velocities, whereas the myocardial performance index was marginally higher in this group, all of them showing that there was myocardial dysfunction that was detected by tissue Doppler imaging in these babies, whereas conventionally or traditionally, if you look at...
Hi, Kiran. I think your voice is not clear. There's a break.
Okay. I will try kind of earphones or speaker and see if it gets any better. Is it any better now?
Better,
Yes,
yeah.
it's better now.
Okay, great, thank you. I'm sorry for that. I don't know where the voice was. My voice was breaking, but I was showing that the tissue Doppler imaging was able to detect myocardial dysfunction in preterm babies with hemodynamically significant PDAs, whereas conventionally, if you were to look at left ventricular outputs, let's say, it would be very hard to detect such dysfunction in these babies. Now my screen has frozen. There you go. Then we look at a different group of babies affected by hypoxic ischemic encephalopathy, and this was a study published by the group from Toronto with Professor McNamara. So they looked at about just over 50 babies affected by HIE, performed echocardiograms on day 1, day 3, and day 4 after completion of rewarming. They categorized the infants further into those who had adverse outcomes on neonatal brain MRIs and normal outcomes. And again, like the previous studies, you can see that both the fractional shortening and surprisingly ejection fraction measured with biplane Simpsons, which we would normally assume it to be better than fractional shortening, were both similar at the 3 time points, whereas the peak systolic velocities of both left and right ventricles were lower on day 1, which is the TH1 on this slide, and gradually improved with time, which is again what we assume with the disease pathology will happen. So again, tissue Doppler imaging was much more sensitive than conventional measures of systolic function to detect poor myocardial performance. Similarly, in an area that is of much interest across the globe now, of congenital diaphragmatic hernia and pulmonary hypertension, and this was Dr. Neil Patel from Glasgow when he did, I think, his research in Melbourne, looked at the right ventricular function in babies affected by congenital diaphragmatic hernia, and we can see that tissue Doppler velocities were able to detect myocardial dysfunction, and there was statistically significant difference when we look at the early diastolic velocities of the right ventricle. And very interestingly, they reported peak velocities of the isovolumic velocities. The peak velocities of the free RV wall, the RVS prime, and the diastolic velocities of RVE prime, and the same early diastolic velocities of the septum as well. So at various sites of septum and the free RV wall in babies with diaphragmatic hernia, again, tissue Doppler imaging was able to detect myocardial dysfunction. So that's, sorry if I kind of rushed through them, some of the studies which showed how tissue Doppler imaging is more sensitive than conventional methods. And the next bit is to look at how tissue Doppler imaging has provided more understanding of the pathophysiology in, again, neonatal populations of affected by different diseases. So this was now, or this is now slightly older, kind of 15, 16 years ago. Andrew Yates in Ohio reported myocardial tissue Doppler changes in patients affected by bronchopulmonary dysplasia. A small group of patients. So they performed, again, a single echocardiogram around term in 3 groups of babies. Group 1 was control infants, so preterm infants who did not have BPD. Group 2 was infants with moderate BPD, and Group 3 was infants with severe BPD. And even though they haven't provided any p-values, you can see that the fractional shortening amongst the 3 groups is quite similar, whereas when you look at the tricuspid and mitral early diastolic and peak and late diastolic velocities, interestingly, they found, so Group 1 is infants with no BPD, and Group 3 is infants with severe BPD. You can see that both the tricuspid and mitral diastolic velocities are higher in infants with severe BPD compared to infants with no BPD. And that was an interesting finding. And in the same study, they reported left ventricular myocardial performance index, which was linearly correlated with the severity of BPD, i.e. Children with BPD had better LV global function, or shorter or smaller MPI, whereas infants with severe BPD had higher myocardial performance index, or poor function. So this was a study, again, we published from Birmingham in the United Kingdom, again, looking at a larger cohort of infants affected by BPD. So again, here we had 3 groups of infants, so all infants born before 32 weeks of gestation. And Group 1, and we again categorize them as infants with no BPD, just to clarify, this is group 3. So group 3 was infants with no BPD. Group 2 was infants with chronic lung disease or BPD, but requiring nasal cannula oxygen, whereas group 1 was infants with chronic lung disease who required positive pressure ventilation, either via endotracheal tube or non-invasively. Again, when you compare all 3 groups, you can see that the left ventricular output and left ventricular fractional shortening was not different or similar across the groups. And this was, again, one echocardiogram performed between 36 to 40 weeks of postmenstrual age. Whereas when you look at the myocardial velocities, peak systolic, early diastolic, and late diastolic velocities at all 3 sites, you can see that group 1 babies, which is babies with more severe chronic lung disease, had higher velocities compared to control infants in group 3. But when you look at their myocardial performance index, the myocardial performance index was higher in babies with severe BPD compared to control infants. And we hypothesized at the time that the higher myocardial velocities was probably in response to altered pulmonary vasculature for the and potentially for increased arterial stiffness in the left ventricle as well. Just to mention that none of them, apart from the peak systolic velocities at the of the right ventricle, reached statistical significance. But interestingly, the last row of the table, if you can see, the isovolumetric relaxation time of the right ventricle was much more prolonged in babies with severe BPD compared to controls. And this either represents poor diastolic function, but more interestingly, I find that in some adult populations with chronic COPD, either smoking related or because of cystic fibrosis, the right ventricular isovolumetric relaxation time has been used as a surrogate for pulmonary hypertension or raised pulmonary vascular resistance. So that's, again, was an interesting finding, making us think about the pathophysiology in these babies. Similarly, we're looking at babies with PDAs, and as Dr. Daniel mentioned, one of our panelists, Dr. Adrianne, has a special interest in this. And this was, again, a study published from the Toronto group, looking at the tissue Doppler velocities in babies undergoing PDA ligation. And as you can see in the table, it shows the measurements before the PDA ligation surgery, 1 hour postoperatively and 18 hours after surgery. And as you can see, there is a marked decline in the tissue Doppler velocities immediately postoperatively, which persists for more than a few hours, probably in the first 1 to 2 days after PDA ligation. And such kind of understanding of physiology in babies is quite crucial if we were to refine or target treatments in these babies. Similarly, again, looking at babies affected by hypoxic ischemic encephalopathy, again, this was published recently, but the study was performed by our group in Birmingham in the UK, and we looked at 20 babies affected by moderate to severe hypoxic ischemic encephalopathy and compared with 20 well-term infants in the postnatal ward. And again, just in the interest of time, I've just put the results at kind of baseline comparison, looking at the tissue Doppler measurements on day 1 of affected infants compared to the control infants on day 1. And as we expected, all the tissue Doppler velocities and the myocardial performance indices of all 3 sites were significantly lower in the babies affected by HIE. What we found interesting in these babies was the last echocardiogram in babies affected by HIE was performed between days 5 and 7, so well after the completion of rewarming, and left ventricular dysfunction kind of persisted, and there are kind of pre-therapeutic hypothermia era studies which have shown such persisting left ventricular dysfunction in these babies even at an age of 1 month. So again, kind of makes us think about following up these babies for longer, not just for their neurological function, but probably for cardiovascular function as well. The next bit I want to touch upon is the prognostication. In NICU, we are often faced with challenging situations, and any additional information we can gain that would help us, in decision making or discussions with the family is definitely a useful tool. And TDI can offer such opportunities when we are dealing with critically ill infants. So this is the patent ductus arteriosus scoring system, again published by Professor Afif Al-Kufash from Ireland. And this particular study, published in 2015, was kind of a multi-center study between Canada, Australia, and Ireland, where they looked at over 140 infants affected by PDA. Echocardiograms were performed on day 1, 2, and a third one around a week of life, and they were able to come up with a composite score, including the gestational age of the infant, the left ventricular output, the diameter of the PDA, and the maximum velocity across the PDA shunt, and incorporating the late peak diastolic velocity of the left ventricle measured using tissue Doppler imaging. And they were able to show that this composite score was different between those infants who were affected by chronic lung disease or death at 36 weeks post-menstrual age from infants who were not affected by it. There was also, very interestingly, a slightly linear relationship. With higher the score, the higher the predicted probability of the primary outcome, which was again chronic lung disease or death before discharge. And again, another very useful tool, when dealing with preterm infants affected by PDA. Again, this was a right ventricular diastolic function. Again, Neil Patel published this data from his research in Melbourne, looking at how right ventricular diastolic dysfunction in babies affected by congenital diaphragmatic hernia would be able to predict their duration of respiratory support. And it wasn't just the duration of respiratory support. They were able to, correlate the duration of respiratory support both preoperatively and postoperatively, and that had some correlation with kind of outcome at discharge. But just looking at the duration of respiratory support in the number of days and right ventricular diastolic dysfunction, in the first graph you can see that the right ventricular early diastolic velocity, the peak velocity, had quite a good linear correlation with the duration of respiratory support in the number of days, in terms of number of days. And this was again done preoperatively on days 1 to 2. A similar correlation was found between postoperative measurements and the duration of respiratory support. This was Dr. Arvind Segal's group from Monash, who published this data on the right ventricular tissue Doppler measurements in infants affected by bronchopulmonary dysplasia and its correlation with or association with respiratory sequelae. Again, I've just put up one table from this study, which shows that along with fractional area change of the right ventricle, tissue Doppler imaging velocities, and again here they've used the peak velocity of the isovolumetric contraction period and the ratio of E to E prime as a measure of diastolic function and the time index of the right ventricle all had very good correlation with the duration of respiratory support in these infants with bronchopulmonary dysplasia. So finally, this is I still feel something which hasn't been explored that much. So that's why I've said this is an emerging area where the use of tissue Doppler imaging has the potential to optimize treatments. And just as an example, this study published on the use of melrinone as a rescue therapy in term infants with pulmonary hypertension. Again, published by Professor Afif El-Kapash, this study shows that those infants affected by pulmonary hypertension, this was a retrospective cohort study, but shows that the baseline measurements, and if you focus at the bottom half of the table, showing the left ventricular peak systolic and late diastolic velocities, were significantly different and improved after treatment with melrinone. So did the myocardial performance index. So again, another area where I think in the continuing monitoring and assessment of effect of treatments, modalities like tissue Doppler imaging can offer immediate assessments on babies to kind of optimize and titrate the treatments. So in terms of summary so far, we have looked at a lot of advantages that tissue Doppler imaging has to offer in the neonatal population. Its relative ease of use, use of familiar Doppler principles is a great advantage. It has been shown to be more sensitive than conventional techniques, and it's a courtside tool, so we don't have to perform a lot of offline analysis. It just does not measure, like the conventional techniques, change in the cavity volume or blood flow or outputs, but provides a measure of ventricular performance. To an extent, it provides a measure of ventricular diastolic function, which is lacking in the conventional techniques, and it has now been well established and validated, and there have been attempts to use it for prognostication as well. So what are the pitfalls or careful considerations we should bear in mind while using tissue Doppler imaging? As I mentioned at the beginning of the talk, we have to note that it is dependent on loading conditions. And the first 2 points of this slide are quite key, I think, and we note that it only measures the longitudinal motion of the ventricle in systole. Just as an evidence for it, I think this was a study done in adult population, adults who went for cardiac procedures and then later were seen in the intensive care, received a bolus of isotonic solution as increasing in preload, and then had tissue Doppler measurements taken. And as you can see, this kind of shows that this is the stroke volume, and then SM is the peak systolic velocity, and the top row is the end diastolic volume. So with the bolus of isotonic solution, there was an increase in the peak systolic velocity in this group of adults, which shows that tissue Doppler imaging is prone to preloading conditions, and that should be borne in mind while interpreting the measurements. We're all familiar with the complex arrangement of the myocardial fibers within both the ventricles, this autopsy specimens show it in quite good detail. And if you were to look at figure C, it shows how even the elliptical shaped right ventricle has circumferential fibers, whereas the left ventricular arrangement is much more complex and has a helical fiber arrangement as shown in this picture. However, we have the slight advantage that 80% of the RV systolic function is due to longitudinal fiber shortening or the excursion of the tricuspid valve annulus, and hence tricuspid valve or lateral right ventricular wall tissue Doppler measurements would offer a very good measure of the systolic function. Whereas in comparison, the left ventricular longitudinal function may only contribute to about 60% of its global systolic function. So just measuring the peak systolic velocities by tissue Doppler sometimes may not be sufficient to get a good impression of the LV systolic function. We have talked about or have mentioned the other pitfalls in terms of image quality and angle of insonation, and this is particularly, as I said, important in certain situations with the left ventricle, and there is a huge potential that the tissue Doppler velocities can be underrepresented if the image quality or the angle of insonation are not ideal, and we might misinterpret that as depressed myocardial performance. There will be variation based on the size of the heart. So bigger the heart, bigger the velocities. Dr. Nestor's group from Norway have kind of looked at ways of overcoming this disadvantage while performing tissue Doppler imaging. It's always mentioned that when we do particularly pulse wave tissue Doppler imaging, that the area of investigation of the myocardium might not be moving, but it might be tethering motion or being pulled by adjacent myocardial areas. And we might be just measuring the velocities of tethered motion rather than the real myocardial velocities. I think there has been always an assumption this is not a big issue in the neonatal population, whereas this is important in adult populations who are affected by coronary artery disease, and there would be areas of infarction, but that is an assumption that hasn't been investigated, whether this is important or not in the neonatal population. And finally, this is a particular challenging issue in the neonatal population with higher heart rates, that both the diastolic waves can overlap each other, and there is fusion, either partial or a complete fusion of the E' and the A' waves, and there has to be understanding that this can happen, and when it does happen, then it becomes difficult to comment on the diastolic function, and we might have to look at let's say the isovolumetric relaxation time as a surrogate measure of the diastolic function. So just a couple more slides. I hope I'm not overrunning time here. How do we use tissue Doppler imaging in our practice? In our QNICH program, we've had this is a young program. We've had about 5 or 6 trainees kind of complete training, and what we have noticed is that once they are kind of proficient with obtaining images and proficient with the Doppler techniques, then they really catch up very quickly on performing tissue Doppler imaging because of its relative ease of use. Once they reach that stage, there is a very quick learning curve initially that they can perform tissue Doppler imaging, obtain the images, and easy interpretation as well. But then because of challenges in different clinical situations, like we've already mentioned, there is probably a longer fine-tuning of the technique. Like any other echocardiography techniques, I think quality control is key, and at CIDRO we attempt to kind of meet as a group regularly to ensure we in a way constructively critique each of these images so that quality control is maintained, and that is key for training as well. In clinical use, do we use tissue Doppler imaging routinely? We are a quaternary center, so mostly we get kind of term or near-term babies, and the common pathologies that we see are pulmonary hypertensions, diaphragmatic hernias, babies who are referred for ECMO kind of evaluation, sepsis, or preterm babies for PDA closure. We have aimed for tissue Doppler imaging to be an integral part right from the beginning of our center. The use is variable mainly because of time constraints, because we are primarily an attending physician delivered service, and sometimes there isn't enough time to perform all the measurements. But in challenging cases, we often discuss it within the neonatal hemodynamic group, and tissue Doppler imaging is a key part of evaluation in difficult or challenging cases. So just to end with an example case where we put it to use, a term baby with left diaphragmatic hernia who was stable on day 1 of life, commenced on inhaled nitric oxide at 6 hours due to increasing oxygen requirements on the ventilator, and showed a good response. So the baby had a pre-inhaled nitric oxide echocardiogram, which showed a low left ventricular output, reasonable ejection fraction, signs of severe pulmonary hypertension, suboptimal RV systolic function measured as TAPSE, and unfortunately tissue Doppler imaging was not done at that time. 24 hours after commencing inhaled nitric oxide, a repeat echocardiogram was done, which showed improved left ventricular output, improving signs of pulmonary hypertension, improving TAPSE, but measurements on TDI were concerning. So the advice from the hemodynamic consult was not to be in the inhaled nitric oxide, but consider escalating support for the right ventricle. And this is the challenge sometimes when you have there is a mismatch between an investigation and the clinical situation. And over the next 12 hours, no support was weaned, but no additional support was offered to the baby. And then clinical deterioration became more evident, and the infant subsequently required multiple entropes, had quite a challenging clinical course for about 10 days before he was ready to be operated upon, and narrowly escaped ECMO. So take-home messages for me are that tissue Doppler imaging is a useful tool. Normative values have been very well established and are available. It has been assessed in various pathological conditions and has been shown to be more sensitive than conventional techniques. It is relatively easy to perform and interpret. And as long as we acknowledge the limitations of this technique, it can be quite a useful tool, and can be quite a useful piece of the puzzle that we have to solve while looking after critically ill infants. It's no magic bullet, but it's a very useful tool. Thank you.
Thank you so much, Kiran. That was wonderful. Really great summary of the topic. And nice to hear some of your practical use of the tool. We will start off with one of the questions from the audience, which is, are there normative data for E to E prime ratio to identify diastolic dysfunction? or is it just trending of the ratios that you would use?
There is normative data in the references I suggested in my talk for the EE prime ratios as well. However, like I said, none of these are kind of magic bullets that we can use on their own. And any measurement, any investigation, a trend of it, I personally feel is much more useful than a single value at any one point in time.
Great. One more sort of technical question. Are there relevant variations among the different manufacturers of the echo machines and the software in particular?
I think I'm understanding the question correctly. I don't think there would be variation in the actual measurements based on the manufacturer, if that was the question. There's probably kind of background software variations in terms of the algorithms they use, but not in the actual numbers we get out of it.
Mm-hmm. I think that was the question here. Maybe we can, oh, go ahead.
Yeah, so a technical question for all the panel. Traditional measurements, specifically time indices in your centers, are you shifting from the traditionally with pulse Doppler changing to doing it in tissue Dopplers, and in which part of the heart? Like for PDA, for example, or when we use IVRT, all that stuff, do you still do it in the traditional way, or are we using time indices by tissue Dopplers?
I'm happy to start. We here at the University of Iowa, we're still calculating time intervals on blood pulse wave Doppler, at least for clinical purposes. But we have started measuring the time intervals on tissue Doppler, which seems to be a bit more precise and cleaner because of the higher frames per rate in the research setting. But clinically, we are still using pulse wave Doppler on blood Doppler.
I think that brings us nicely to the question about the intra-observer and inter-observer variability when utilizing the new tools like tissue Dopplers assessments. Being not a new tool on the block, but less experienced tool, I think integrating into the practice should be guided, in my view, after knowing that what variability we are encountering while using for IVRTs, for the TDI incorporating in a clinical practice. So I believe the question was about, are we using it routinely? The answer, I would agree with Adrianne that I think it is a part of the research tool primarily, but not as a part of the clinical integration. I don't know what others feel.
And yeah, please.
I was just going to say, what do you think is the highest yield area to focus on? If you're, if we're trying to learn more about the measurement and determine how we can adjust therapies based on it, where do you think, the biggest impact will come, if you could speculate? Like what diseases?
I feel the biggest population that we probably haven't tapped upon is the preterm population, the extreme preterms, transitional circulation in the first 2 to 3 days, maybe the hypotension in extreme preterms in the first week of life. I think these, I think that area, because there is a lot of normative data on such populations, but I guess, and I can say from personal experience, I think we had an attempt at doing this in our group in Birmingham, and it was extremely challenging to, both not technically, but kind of getting the right babies, getting consent, So I think that's probably a big area where there is still a lot of potential.
And for example, the scenario where you have altered intrinsic myocardial function or contractility, but you still have maintained myocardial performance, that is which we normally report when we do an hemodynamic consultation. How frequent is it? Like, I don't know, I know we don't have a number, but how in your point of view, how common is that we're using it for decision making, like in the last case you presented?
I think individually on its own, I think it's very rare that we use tissue Doppler imaging for decision making, and I think somehow I think we still haven't taken that step of using it on its own, probably because of its inherent difficulties and challenges that we know it has. But like I said at the end, I think it's the it's used as a piece of the puzzle that we have to solve. I think that's where it's useful. So like in the last case, if everything seems rosy, but then we have some measurements which are not ideal, at least we can then use it or have it in the back of our mind to then not be aggressive at weaning therapies, let's say, like in the example case that we used. So I think it's still an adjunct rather than a sole measurement on its own.
Yeah, I think there might be a role in the upcoming trend of using it in kind of like a scoring system. Like Dr. DeWall in Australia, who uses it, the E prime or the E to E prime as part of their scoring system for assessment of diastolic function. So I think I don't see it coming it on its own. I think the multi-parametric approach for all sorts of diseases and usages is what's going to be the ongoing trend. It would be great if we could use one technique for all the things, but that's not where hemodynamics is going. That's not where targeted neonatal echo is going.
No, I think that holy grail is not there.
Yeah. And that seems consistent with all of medicine, right? I mean, we don't have one answer to any question.
I would at this point like to bring up a question about the variability, which is I think quite important when we are harmonizing a practice, to be honest. The scoring system I'll take that example of, and I'd like to have the views of the panelists for that. Say the scoring system which has taken 5 parameters, the Rios criteria doesn't change, is a gestation or accrued indices like the LVO, etc. But when we start incorporating more than 2 or 3 parameters in a particular score, the individual scoring or individual measurement has its own variability inherent. And when you combine 2, 3, or 4 or more criteria in a score, what is your view of the validity and the reproducibility of the score when 5 different people or 10 different people are doing the same score? What are your views about that?
I'm going to ask Adrianne to answer that question. Seems perfect for you.
Yes, thank you. Yeah, no, that's a really good consideration. Every marker will have problems. The more you add, the more variability there will be in the score. I don't think one of the ways to account for that is not using a single cutoff. We're not going to say out of a PDA score of 10, if you have 5 points, then you have X disease, but rather perhaps using ranges to account a little bit for that variability. That's kind of how we use our PDA score, which doesn't even include any tissue Doppler imaging. It's more like a range, because you acknowledge that some of the markers are influenced by other things, that there may be inter-rater reliability problems. So that's kind of what I can think from the top of my head. I don't know if others have different thoughts.
One thing that I would sort of believe, I guess, is that we need to be testing the scores more. I think that we've had a few good studies of some of the scoring systems, but if we change population, or we change the measurements at all, I think we need to retest and then test them with, you know, in practical use, you know, like hopefully, you know, we'll learn more from the PDA study, whose name I'm blanking on at the moment, but I think that, you know, in order to like really use them well, we have to test whether, you know, using them as a decision-making tool is really beneficial.
And making sure that we stick to the populations for which they were designed to, right? If with the normative data for the different diseases and different gestational ages, it changes so much, right? If you were to use tissue Doppler specifically, for example, the HIE cooling term population, who have their own inherent set of loading conditions, who have a low heart rate, which will impact within the tissue Doppler domain, just the velocities as well as the time intervals, is very, very different than using tissue Doppler on 24-hour-old 24-weekers whose heart rates are not 100, but actually 160, and who have a different set of loading conditions and PDA and everything else. So I think that's also very important, that we can't just pick one table of normative data and think that it's applicable to everyone, but it's actually everything is very complex and it's not easy, which is why training for this and doing consults in hemodynamics is so difficult and takes a lot of training, because of all these nuances that sometimes people don't necessarily acknowledge.
Oh, that's great, Adrianne. I think that's a kind of line of thinking that that I had. One of the population differences, keeping ranges rather than cutoffs, and that would minimize the bias inherent due to the scoring and taking various factors into account. And if I may just ask Kiran one point, from the various measurements that you suggested for the TDI, if as a take-home message people have to adopt a couple of measurements which could be reproducible and also help in decision making and understanding the underlying pathophysiology, do you think the tie index and the EE prime are good take home for the TDI, or do you have any alternative view?
I feel like a trick question has come my way. Because I think like we just talked about for the last few minutes, I don't think there is one, because like in the few examples that I quoted, I think each study had a different marker that was significant. So I think the key is to where the clinical situation allows to get a comprehensive evaluation. Look at, because not just a single population of infants, but each infant would be different. And each infant's, physiology and pathophysiology would be different within the same disease state. So I think it's tricky to kind of pick one or two measurements within tissue Doppler. I would say, I think as a baseline, there should be, a comprehensive evaluation within the functional echocardiogram done. And then the follow-on or trending values, then you could probably focus on a few, would be my view.
Seems very rational. Daniel, did you want to add?
No, I just wanted to add on the previous discussion about using the scoring system, that I completely agree with Tina, that I think we have similar scoring systems in other areas of neonatal medicine. Like, we have recently been discussing about the sepsis scoring system in early onset sepsis, that is much more widespread now. And the take up for that is much more because it has been tested in a larger cohort of neonates. So there is much more confidence that the scoring system won't fail us in a way. And it's one good example where we're using a scoring system for decision making rather than just prognostication. So I think it's really important that these scores are tested and validated by different groups in different centers, and then once we have some consensus about where its real use is and how much it's useful, then we can put it to clinical use.
Well, it's been a really
I just wanted to ask. Sorry,
yeah.
It's my turn to ask questions now. I think that I know Adrianne has said that they in Iowa they still use tissue Doppler as more of a research tool rather than in clinical. And I just wanted to know from the other panelists whether because we have tried to kind of integrate it as one of the measurements that we will get. And like I said in my talk, I was feeling that why aren't we using it more? But maybe we are using it, in line with others, or maybe we are using it optimally. But I just wanted to know from other panelists as to how much clinical use of TDI is done in your centers.
Just to clarify before the other ones go ahead, we're not using time intervals from tissue Doppler clinically. That's only for research purposes, but we are using the S prime, E prime, and the ratio of E to E prime clinically. And we use it not as in a score necessarily, but as part of a multi-parametric approach. So for example, if we're assessing RV systolic function, we're going to look at RV S prime, TAPC, FAC, strain, and if you have 4 measurements and all of them are kind of telling you the same thing, then we're more robust at saying yes, there is X amount of heart dysfunction on the right ventricle. Whereas if you have a normal TAPC, a normal FAC, a normal strain, and only the tissue Doppler is a little bit abnormal, then we're like, well, maybe it was angle dependent, maybe it was heart rate dependent, maybe it was a method specific problem that we should not be taking into consideration. And same thing for the LV and the diastolic aspect of it. So we are using it clinically, but not as a single measurement to define our therapies or strategies, but as part of the multi-parametric approach, at least in terms of the velocities, not time intervals yet.
Any other thoughts about how others use it?
Okay.
Seems like we have lots of work to be done.
Well, I think we can end the session now. If anyone has a final message, Kiran.
No, like my take-home message slide was that it's a very useful tool, and agree with Tina, more work to be done, I think.
Thank you so much for really giving us a great presentation and a lot to think about. And thanks to all the panelists for joining us.
For the time. Yeah.
Thank you very much.
Thank you.
Thank you.